Yes, good morning, everybody. Good afternoon or good evening, according to your time zone. I'll start right now. So, treatment of complicated and failed reconstruction of anterior shoulder dislocation. We all know that ligamentocapsular structure is attached on the glenoid and humeral sides to form some sort of hammock on which lies the humeral head. And Bankert lesion means detachment of the hammock from the glenoid side. Open or arthroscopic Bankert repair was the standard treatment of anterior shoulder dislocation. But how far this is true? Many authors found that failure after open Bankert repair was high. It may reach up to 17%. And the same story after arthroscopic Bankert repair, it may reach up to 50% of the cases. So they start to ask questions. Why do we have such a high failure rate? And who are the patients who are at risk for failure after Bankert repair? Is there another lesion that wasn't recognized and has not been treated? And so they look for other treatment options. One of these surgeons is Pascal Boileau, who just studied in 2007 a cohort of 131 patients treated with Bankert repair. And he found that failure of Bankert repair was about 15%. So he looked into some risk factors like young age, type of sport, either contact or forced overhead sports, the level of sport practice, either competition or recreational, the presence or absence of hyperlaxity, presence of heel sacs, presence of glenoid bone loss. And he gathered all that in a table and just he puts a points for this. And he introduced to us something called the instability severity index score. And he found that patients who had less than 3 points, the instability recurrence rate was 5%, which was acceptable. But those with more than 3 points, they had an instability recurrence rate about 70%, which was not acceptable. So he concluded that when ISO score is less than 3, the patient is a good candidate for Bankert repair. But when it's more than 3, this is a formal contraindication for Bankert. From the previous data, we found that the contraindication of Bankert repair may be the following. Like in patients who are indulged in extreme sports activity, like rugby, martial arts, etc., or patients with failed previous stabilization surgery who needs revision surgery, either Bankert or remplissage or whatever, or patients who have a poor ligament quality or Hagel lesion or disrupted or thin capsule. So in this patient, if we do a Bankert repair, it will fail. As you can see in this video, Hagel lesion. Or the presence of big bone loss, either on the humeral side, like a big heel sacs, or on the glenoid side, or sometimes on both sides, which we call bipolar lesion. A significant bone loss, it's a term which was introduced by Burkett de Boer in 2000 when they discovered an inverted pear-shaped glenoid. When there is a bone loss, more than 25% of the inferior glenoid diameter. And this led to engagement of the heel sacs in 90-90 position, and of course, dislocation. Another term which was introduced by Yamamoto and Ito in 2007, which is the glenoid tract, that's defined as the area of contact of the humerus against the glenoid goes up. From cadaveric study, Yamamoto showed us that the glenoid pushes the cuff about 16% of the glenoid width. And so the glenoid tract is about 84% of the glenoid width measured from rotator cuff attachment. It goes without saying that when there is a glenoid bone loss, the glenoid tract narrows. So to measure the glenoid tract, we just measure the 84% of the normal glenoid width. And then from this measurement, we subtract the glenoid defect width to have the glenoid tract of a certain individual. Di Giacomo et al. In 2014, they published an interesting paper titled Evolving Concept of the Hill Sachs Lesions, from engaging, non-engaging lesion to on-track and off-track lesion. So in this paper, they showed that if the Hill-Sachs is within the margin of the glenoid tract, so no engagement and no dislocation, and we call it as an on-track lesion. And on the right side image, if the medial margin of the Hill-Sachs extends beyond the glenoid tract, so there will be engagement during abduction, external rotation, of course, dislocation, and we call this an off-track lesion. Omori et al. Found that the glenoid tract is not 84%, but it's 83% of the glenoid width. And of course, when we do a 3D CT scan, we can just do the measurements and calculate the glenoid tract. So Di Giacomo, he just introduced the treatment paradigm. They divided the patients into 4 groups. Group 1, when there is a glenoid defect less than 25%, and on-track Hill-Sachs lesion, we can do arthroscopic Bankert repair. But in other cases or other groups, arthroscopic Bankert repair would be a failure. So if we have off-track Hill-Sachs lesion or a glenoid defect more than 25% or both, now we cannot do arthroscopic Bankert repair, but we should treat these patients with another option like remplissage, Latarjet, or even Latarjet remplissage, which is almost never needed, as they mentioned in their paper. So it's very important. Pre-operative and intraoperative planning is very important, and we should ask what's the kind of the lesion? Is it a soft tissue lesion, a bony lesion, or we have both kinds of lesions? And in case of bony lesion, where its location, on the humeral side, on the glenoid side, or do we have a bipolar lesion? My preferred method of treatment in such complicated or failed cases, I do Latarjet procedure after Michel Latarjet, who just invented this procedure in 1954, and it has a bone block effect plus the sling effect of the conjoint tendon. I had the chance to do a 2-year fellowship with Laurent Lafosse, who invented it to do it arthroscopically, and I'll show you just an animation how we do it arthroscopic, not in open technique. So we have, this is the coracoid, this is the CA ligament, we detach it from the coracoid, the pec minor, we detach it also from the coracoid, switching stick from the posterior portal to identify the site of the subscap split, we do the split, and then from a superior portal, we introduce this instrument with 2 K-wires and then 2 drill bits to make 2 holes. And then we pass the chair through the holes and take it, the 2 limbs from the superior portal. We introduce something called the top hats to increase the purchase of the screws. And then from anterior portal, we introduce this instrument to retrieve the 2 suture limbs, the 2 limbs of the chair, sorry. And then after that, we do osteotomy of the coracoid to attach the coracoid to this instrument by 2 long screws. And then we pass it through the subscap split to make sure that it is well applied on the anterior surface of the glenoid. And then K-wires followed by cannulated drill bits and cannulated screw in the inferior hole, as you can see. And we repeat the same thing with the superior hole. Cannulated drill bit through the K-wire, we make the hole, and then we introduce our cannulated screw through the superior hole. We make sure that the coracoid is flush with the glenoid, and then we remove everything. This is a arthroscopic image, how we do it. This is the humerus, the glenoid. This is the coracoid, and we can see here the screw through the superior hole. This is the final picture after screwing it. This is the coracoid, the 2 screws, as you can see, the humeral head and the glenoid, and it's well flush with the glenoid surface. Another arthroscopic image, the glenoid, humeral head, the 2 screws, and you can see the conjoint tendon passing through the subscap split, and the coracoid graft is well flush with the glenoid surface. This is one of my cases after 1 year. You can see the image pre and post operatively, and the CT, which shows a very good healing of the coracoid graft. As regard the results, more than 50 patients into the mean follow-up of about 34 months. Return to work after 2 months on sport, after 2.5 months, 94% had excellent results. The range of motion, we have like average loss of external rotation of about 18 degrees or less. And as regard the complications, 1 hematoma, 1 graft fracture, and 1 case of transient musculocutaneous nerve palsy, which recurred after a few months. And for the late complication, we had 4 cases of graft non-union and 3 cases of graft lysis. But surprisingly, none of these patients had an episode of dislocation or apprehension. Graft position was flush with the glenoid in 91%, and vertical position was excellent in 94% of the cases. We all know that Latarjet is being criticized as being a non-anatomical reconstruction, but actually, this surgery is a very successful to reduce apprehension and recurrence as much as possible, and to return to full sport activity. So, in summary, patient history is very crucial, like age, type of sport, level of sport, etc. It's very important to have an intraoperative assessment as preoperative assessment, because sometimes when we go inside, we may change the decision from Bankert repair to Latarjet if we find, for instance, a thin capsule or defect labrum. CT should be done in every case of shoulder dislocation to detect bony lesion. This is very important because Segai et al. In 2003, she showed us that about 90% of cases with anterior shoulder dislocation have bony lesions. Thank you very much.